I would like to welcome everyone to the Osteoarthritis Action Alliance Lunch and Learn for May 11th, 2016. My name is Kirsten Ambrose, and I want to thank you all for joining us. May is Arthritis Awareness Month, as many of you probably have heard by now, and we have a special webinar for you today. I'm pleased to introduce our presenter, Dr. Yvonne Golightly. Dr. Golightly is a research assistant professor in the Department of Epidemiology at the University of North Carolina at Chapel Hill. She's a faculty member of the Thurston Arthritis Research Center and Injury Prevention Research Center here at UNC, and she's also the Grants Program Officer for the OAAA Action Alliance for our Small Grants Program, which is currently live. Her research focuses on the long-term effects of musculoskeletal injury and disorders of the lower extremity, with particular interest in identifying modifiable risk factors for injury and OA and developing treatment and prevention strategies. Today, Dr. Golightly will give us an overview of osteoarthritis, including our current understanding of the disease, common symptoms, and management strategies. So welcome, Dr. Golightly.
Thank you, Kirsten. So today's talk will be a quick general description of osteoarthritis. So the topics that I will be covering, we'll talk about what is osteoarthritis, how common it is, the public health impact of osteoarthritis, risk factors for the disease, and some of the treatments that are available for OA. So what is osteoarthritis? It is a disease of the joint that affects all the structures in and around the joint. Cartilage is a tissue that you find on the end of bones, and it helps with smooth movement of the joint. In osteoarthritis, what happens is it deteriorates, as you can see on the right-hand side of this slide showing osteoarthritis, where there's a loss in cartilage density, where the cartilage becomes more fragmented. In osteoarthritis, we also see changes in bone with bone spurs and areas of altered bone density. Now, bone does contain nerves, so when cartilage deteriorates and the bone is exposed, people can experience pain. And you may have heard of the phrase bone-on-bone arthritis, and what this means is that the cartilage is so severely degraded that the person ends up developing severe osteoarthritis. There are a number of different definitions for osteoarthritis. For clinical osteoarthritis, this is based on abnormalities that can be seen on physical exam that are consistent with OA. So this may include changes in the hands with the nodes. So these are bony swellings. There can be crepitus or grinding of the knee joint when the knee moves, or there may be limitations or pain with internal rotation of the hip. For radiographic osteoarthritis, this is where we're looking for any changes in the bone, such as bone spurs or osteophytes, or any changes in joint space narrowing or cartilage loss that we can see on X-ray. And then for symptomatic osteoarthritis, this is pain or stiffness in a joint with radiographic osteoarthritis. Some of the features that we look for on X-ray for osteoarthritis include joint space narrowing. So the image on the left is a joint where there's pretty good space between the bones, which indicates that there's still healthy cartilage there. On the image on the right, where the yellow arrow is, what we see here is there's a loss in that joint space, and that indicates loss of cartilage. We also look for osteophytes or bone spurs, and then we look for sclerosis, which is a denser area of bone just under the cartilage. For osteoarthritis, it really can occur in any number of joints. It can be in one joint. It can be in many joints. There are a number of locations where we see it most often, which include the hands, knees, hips, spine, and the feet, although it is also seen in other joints like the ankles, the shoulder, and the jaw. And some of the general symptoms that we see in osteoarthritis include pain that occurs when the person uses the joint. Their pain does tend to get worse as the day goes on. They may have some stiffness first thing in the morning, but it doesn't last for a long period of time. It doesn't last for hours. They may have stiffness after periods of inactivity, so if they sit for too long. They can have loss in range of motion. They may experience joint instability, bony enlargement, crepitus, or grinding of the joint, and then swelling. And then more specifically for the hand, what you may see is bony enlargement of the joints that are either at the ends of the fingers or more in the middle of the finger. The image that's on the right, it shows nodes in that finger, and those nodes may be inflamed or warm. You can also have involvement of the first carpometacarpal joint, which is the joint at the base of the thumb. We often see that both hands are involved with osteoarthritis of the hand, and then it can be in multiple joints. And then for the metacarpophalangeal joints, those can also be affected, so those are the joints that are at the base of the fingers. And then for the knee, what we see is that there's pain with limited range of motion, and this can affect daily functions such as walking, transferring, getting up and down from a chair, or going up and down stairs. The person can also feel unstable on that knee and have a locking sensation in the knee too. They can experience that grinding, bony enlargement, some swelling, and although that swelling, it's often not warm to the touch. You don't notice a lot of redness with it. And malalignment of the joint is often seen in severe osteoarthritis. So what this is, on the left-hand side, what you see is normal joint alignment at the knee. The one in the middle is varus, so what this is being more bow-legged, and for an individual who has more of that bow-legged position, we may see that they have more osteoarthritis on that medial or inner side of their knee. And then there's also valgus alignment of the knee, so this is more the knock-kneed position. And then for the hip, we see groin pain. We see pain in the thigh, the buttock, the low back, or even in the knee on the same side as the affected hip. There can be limitations in daily activities. There can be a limited internal rotation, so the ability of the person to turn their hip inwards. And in very advanced disease, we can see much more deformity. They may develop what's called a contracture. So basically, they have a tightening of the muscle that limits their motion. So how common is osteoarthritis? The numbers that I'm presenting here are for arthritis in general, but osteoarthritis is by far the most common form of arthritis. So about 22.7% of adults had arthritis in 2010 to 2012. And it's estimated that by the year 2040, about 26% of adults will have OA. And then the lifetime risk numbers are very impressive, with 1 in 2 anticipated to have knee osteoarthritis and 1 in 4 people with hip osteoarthritis. When we look by joint, what we see is that for the hand, having a radiographic hand osteoarthritis in at least one joint in adults who are 55 years of age or older, 67% of women have hand OA and 55% of men have hand OA. For radiographic knee osteoarthritis, depending on the population that you look at, the numbers vary between 14 to 37%, and for hip osteoarthritis, they vary between 1 to 27%. So what is the public health impact of osteoarthritis? It is the most common cause of disability and work limitations in adults in the United States, and about 43% of adults have arthritis attributable limitations. And then 24% of adults have doctor-diagnosed arthritis that where they are also not participating in leisure time physical activity. And so this is a greater percentage of people not participating in physical activity with arthritis compared to those without arthritis. The costs are very considerable, exceeding $100 billion per year for osteoarthritis. And a lot of this is hospital expenditures for joint replacements. In 2009, it was about $28.5 billion for knee replacements and $13.9 billion for hip replacements. And there are a number of job-related costs with osteoarthritis, including work lost, and that's $3.4 to $13.2 billion per year. So osteoarthritis is a big public health problem. What we do know is that osteoarthritis is linked to obesity, and obesity is linked to a number of other diseases, including diabetes, cardiovascular disease, and hypertension. And often individuals who have the diseases that are on the right-hand side of the screen, they're told to be physically active as part of their management of the disease. One of the issues is if that person has osteoarthritis, they're less likely to want to be physically active. So in thinking about ways that we need to manage a number of other diseases, arthritis really is a part of the picture. So what are the risk factors for osteoarthritis? There are person-level risk factors that include sex, race and ethnicity. We do see it in individuals as they age. We also see it with obesity. And some of this with obesity may be related to metabolic factors, nutritional factors. And then we also see it with genetics. And all of these person-level factors are related to susceptibility to developing osteoarthritis. And then there are also the joint-level factors. So this also includes obesity because we can see with individuals who have greater weight that there's more loading on their joints. So it's a biomechanical factor. Other joint-level factors include joint injury, malalignment, joint deformity, and joint shape, bone density, muscle weakness, leg length inequality, occupation, and then physical activity, especially sedentary behaviors. And this is more what the joint level factors do is they contribute to where one develops their osteoarthritis, which joint site, and how severe their disease is. So the factors I'm going to talk about the most in the next couple of slides are the ones that I've indicated here in these red boxes. So these data, looking at prevalence of osteoarthritis by sex, are from different populations, and you'll notice that they are in different age groups. And although there is some variability across age groups and populations, we do tend to see that osteoarthritis of the hand and the knee is more common in women than in men. And then we do see that there are some racial differences in osteoarthritis in some work done by my colleagues with the Johnston County Osteoarthritis Project, which is a study that looks at African Americans and whites, population-based project. What they have found is that hip osteoarthritis is more common in African American men than in white men, although we don't see a great difference when looking at women. And then for looking at knee osteoarthritis in models where we control for body mass index and for age, again, we see that African American men are more likely to have knee osteoarthritis than white men. Again, not a great difference when we look at women unless we look at more severe osteoarthritis of the knee, where there is a greater odds of knee OA in the African American than in the white women. So we tend to think of osteoarthritis as a disease that occurs with old age, but actually that's being questioned at this point. There are some very recent data. The National Health Interview study looking at 2007 to 2008. In this recent study, what they found is 14 million adults had symptomatic knee osteoarthritis. And about 2 million of those with osteoarthritis were under the age of 45. And then 6 million were between the ages of 45 to 65 years of age. So what this means is that over half of the adults in this with symptomatic knee osteoarthritis were actually younger than 65. And this was a slide that was kindly provided to me by Dr. Richard Loser, who's done a lot looking at aging and osteoarthritis. And what you'll notice is on the left-hand side, we see a joint that's from a young individual who does not have osteoarthritis. And the bottom image is showing a cross-section of the joint looking at the cartilage, and so we see nice, thick, healthy cartilage. The two joints on the right are actually from individuals who are older, who are about the same age. The one does not have osteoarthritis, and the other one does. And what we see is that although with older age there is some loss in the cartilage thickness, it's still pretty dense, pretty healthy looking in the individual that's old normal. But we do see in the individual who's around the same age who has osteoarthritis that they've had considerable changes in cartilage and bone in their joint. So what this means is that osteoarthritis isn't just a disease of wear and tear, and it's not an inevitable consequence of aging. And given that osteoarthritis is so common in the older adult population, it's also of interest to look at some of the factors associated with not having osteoarthritis. So there was a community-based study of 90-year-olds living in the Netherlands, and what they did was they looked at individuals who did not have any osteoarthritis in their hands, hips, and knees. And what they saw was that these individuals were more likely to have a lower body mass index. They didn't have a history of osteoarthritis, and they did see that absence of knee osteoarthritis was associated with being male. So these are some population-based data from the National Health Interviews Survey that show a slight increase over time with aging, which you really see among the non-obese, with around 10% of 85-year-old women and men having osteoarthritis. So what seems to be driving that increased prevalence that we see in obesity over a life, or that we see with age over a lifetime? What we see is that it's obesity, so that individuals who are the obese men are about 20% of them have knee osteoarthritis, and about 30% of them have osteoarthritis by age 85. And then these are data from the Johnston County Osteoarthritis Project that show the lifetime risk for knee osteoarthritis, which is 44.7%. And then when we look at individuals who are obese, actually about that lifetime risk increases to about 60%. And what else can drive up the lifetime risk? What we see is a history of injury, also about a lifetime risk of 60%. So injury is an important risk factor for osteoarthritis, and we conducted a study looking at data collected in 2001 from over 2,500 retired National Football League players, and compared to their data to those of the general U.S. male population. And what we found is that among those who were 24 to 34 years of age of the NFL retirees, about 30% had osteoarthritis, and they look about the same as those that we see that are 55 to 59 years old in the general U.S. male population, who also have a prevalence of about 30%. So what we see here is that injury accelerates the progression to osteoarthritis. Now, what are the treatments for osteoarthritis? So osteoarthritis is a chronic disease that does not have a cure. So a lot of the goals of treatment include managing symptoms, maintaining or improving joint mobility and flexibility, enhancing physical function, maintaining a healthy weight, and trying to achieve recommended levels of physical activity. Some of the treatments that are commonly used that have been supported by a number of guidelines include instruction in joint protection, use of assistive divisor braces, using heat or cold. There's some different medications and injections that can be helpful. There are self-management programs and exercise programs. And for patients who are overweight, weight loss is important. And then for individuals who've tried everything else, joint replacement is an option for severe disease. And there are a number of exercise programs for arthritis that are available, and more information can be found on the CDC website that I have at the bottom of this slide. There are some programs that may be available in the community, like at a community center, a wellness center, or Parks and Rec facility. And there are some programs that are self-directed, like the Walk with Ease. But exercise alone may not be enough for people who are overweight or obese, and there are data from the Intensive Diet and Exercise for Arthritis study that show the importance of diet. And among overweight and obese adults with knee osteoarthritis, after an 18-month-long intervention, the participants who were in the diet plus exercise group or in the diet group had more weight loss and greater reduction in some of the markers of inflammation compared to those who were in the group that did just exercise. And those in the diet group also had greater reductions in some of the compressive forces at their knee compared to those in the exercise group. So you may be wondering why there are few effective treatments for osteoarthritis, and some of it has to do when in the disease phase we are often first seeing the patient and trying to help them. And this chart helps explain this. What we see here is that there's a comparison of intervention points for osteoarthritis with cardiovascular disease and hypertension. So many of you may be familiar with the approach to managing cardiovascular disease early. We try not to wait until the patient has that heart attack or heart failure, but we try to do things early on, looking at their blood work, looking at the abnormal physiology where there may be increased levels of blood lipids, and trying to intervene at that point before they have that symptomatic disease. When it comes to osteoarthritis, what happens is we often have that patient right when they're at that end-stage symptomatic disease, and it gives us very few options. So there is a lot of exciting research that's going on right now to try to identify some of the early joint metabolic abnormalities that may be occurring. Some of these markers may be on images like MRI, biochemical markers that show cartilage turnover or inflammation in fluids like blood, urine, synovial fluid from the joint, or biomechanical markers that may show abnormal movement patterns early on that are linked to the development of osteoarthritis. So in summary, osteoarthritis is the most common form of arthritis, and it is a leading cause of disability. And it likely represents a final common pathway of a number of different factors. There are personal level risk factors that include age, female sex, obesity, genetics, and metabolic and nutritional factors. And then there are also joint level risk factors that include injury, obesity, occupation, physical activity, muscle strength, joint alignment, leg length inequality, and bone or joint morphology. And OA is not simply a wear and tear disease, and it is not an inevitable consequence of aging. And signs and symptoms of OA include pain when using the joint, pain that worsens throughout the day, some morning stiffness, although it's minimal, decreased range of motion, joint instability, bony enlargement, crepitus or grinding of the joint, and variable swelling. And there are few treatment options for OA at this time, and there is a need for a more proactive approach to osteoarthritis management. So I thank you very much for your time, and I welcome your questions.
Thank you, Dr. Golightly. Very, very interesting and nice, good overview of osteoarthritis for all of us, I think. I think it's an interesting, somewhat newer mindset or understanding that this isn't so much a disease of wear and tear. You know, you mentioned that a couple of times in the talk, and I know you also touched on the connection with obesity, and certainly when you think about hips and knees, you put a lot of pressure with excess weight on those joints. Those are load-bearing joints, weight-bearing joints. But, you know, you see osteoarthritis in the hands in quite a few people who also have obesity. So that's another indicator, I think, that it's not wear and tear. Obviously, your hands are not loading. So what are your thoughts about OA in the hands and some of the inflammation that can occur?
Yeah, I don't do a lot of work with obesity at this point, but at least of what I'm aware from reading the literature, we do, as you mentioned, we do see that individuals who are obese are more likely to have hand osteoarthritis, and this doesn't seem to be biomechanical. We're not doing as much on our hands or loading on the hands. So it does seem as though osteoarthritis obesity does affect osteoarthritis in many ways that are more than biomechanical, that do seem to be metabolic. And we do see that individuals who have metabolic syndrome are also likely to have osteoarthritis too. So it may be an important component.
And we do have a question that's come in. Is there a known relationship between high-impact exercise and OA, like running or aerobics?
Oh, that's an excellent question. I have some work where they're finding that there does seem to be a benefit to having some impact on the joint. You do want to load it to some point, but you don't want it to be too much loading. There also seems to be some problems with not having enough loading to the cartilage. For certain individuals that we're doing some work with in the military right now, what we're finding is that we're recommending to them that we want them to be physically active, but if they are having some problems with their joints, that they may not want to be doing some of these higher impact activities since they already have some joint injuries or some things that put them at greater risk for developing osteoarthritis.
Thank you. And for anybody who does have any additional questions, you can certainly chat them in our chat box down there on the right-hand lower right. And just as a reminder that we will be posting this webinar. I think this has been a really great overview, like I said, and it will be a nice resource to have for you all to share or to revisit anytime that you want to check in and get some stats and some updates on your OA. Like I said, do share with any colleagues or patients or anyone that you think would benefit from this kind of thing. That's one of the things that we like to do at the Alliance, is to provide educational resources like this. So I'll have this posted later on today on our website and on our YouTube channel, which is where we keep all of our webinars archived. And one other question has come in. What nutritional factors are most important in the development of OA? That's an area that
we... That's an excellent question. Yeah, so again, this is an area where I don't know as much, although I'm aware of some work that has suggested that sort of the Western diet, the diet that's higher in fat, higher in sugar, may be important in the development of osteoarthritis. So I do have some colleagues that are looking at mice, and some of what they do in looking at the development of osteoarthritis is giving them more of that high-fat, high-sugar diet.
Okay, that seems to be a culprit in a whole lot of of our current chronic illnesses, high fat, high sugar. So, one of the things that we've noticed is or one of the things that we're also trying to promote in the Alliance is connecting OA, like you did so nicely, Dr. Golightly, with other illnesses, cardiovascular disease and obesity, diabetes, that sort of thing. It does travel along so often with these other illnesses, and management strategies are very often the same, with proper diet and more physical activity and managing weight and that sort of thing. So I think it's really key to keep all of these illnesses in the same conversation and being, if you can treat or impact one, you're very likely going to help the others. One other question is physical.
Yeah,
I was just going to...
I see the question.
Okay.
So the question is physical therapy helpful for people with symptomatic osteoarthritis? So physical therapy, it is recommended as part of the guidelines for treating osteoarthritis. And there are a number of things that physical therapists can do that at least help with enhancing physical function. So people with osteoarthritis can develop loss of function, develop disability, and so some of what physical therapists can do to help them maintain or regain function include braces or assistive devices that may help with walking if they're limited in their ability to walk, can also give them exercises to help them manage their osteoarthritis. In some respects, some people may be too far advanced with their disease at the time that they're seeking care, that physical therapy may not have a lot of an impact. And that might be a time when the patient has to think about surgery or joint replacement.
Okay, so we'll certainly welcome more questions as they come in. We've been about 30 minutes from the start of the talk. We're a little bit over our time, so I just wanted to give a quick announcement for our next Lunch and Learn on May 18th. That will be with Dr. Michelle Seeger from the University of Michigan on ways in which the simple science of motivation can lead to a lifetime of fitness. So be on the lookout for that. That will be another interesting one for, I would say, all of us. I think at any point in time, any of us can struggle with motivation for exercise, so that will be helpful. And if no other questions are out there, I just wanted to take a minute to thank you very much, Dr. Golightly. Extremely interesting talk, and I think a great update and nice overview for our understanding of OA. Thank you.
Oh, thank you.